Hi, everybody. Welcome back to the channel. This is Dr. Wardwell. I'm a general practice veterinarian and soft tissue surgeon at Viking Veterinary Hospital in Idaho in the United States. First, I want to apologize for the audio. Something happened with our audio during the procedure, and we didn't capture anything live. So I apologize for no actual surgery background sounds. But this is a very interesting and unusual case. This is a case of a 8-year-old, 9-year-old Labrador Retriever that presented with signs of hyperthyroidism, essentially drinking a lot and being anxious and losing weight and having a really strong appetite, vomiting. And it turns out that the dog has a functional thyroid carcinoma, meaning it has a tumor on its thyroid gland that is functional or is producing what that gland would typically produce, which in this case is thyroid hormone. The thyroid hormone is responsible for your metabolism, essentially. And so if it's present in a really high amount, your metabolism is going to be on overdrive, and it makes animals and people feel amped up and anxious. And so it's very consistent with everything this dog was exhibiting. And so a mass was present on the neck at exam, and we did an aspirate of that and confirmed that it appeared to be a carcinoma. And that's actually a little bit unusual as well for thyroid tumors. Usually they're so vascular that if you try and aspirate them, all you get is blood. You're more or less doing an aspirate to rule out some other type of tumor that just happened to grow in that same neighborhood. But in this case, the sample was not very bloody. There were definitely parts of the sample that were consistent with some sort of a cancerous growth of the type of carcinoma that we would expect with a thyroid tumor. So we planned to take that tumor out, and when we were prepping the patient surgically, my nurses noticed another swelling a little further down on the other side, and it turns out that this dog actually has bilateral thyroid carcinomas. And so the owner was contacted, and we told her what we found and said, we can still go ahead with surgery. And so the owner consented to that. So what we're doing is a bilateral thyroidectomy for functional thyroid carcinoma. And the main complication with this particular procedure would be that the parathyroid glands are closely associated with the thyroids. One is located inside the thyroid gland, and one is sitting right on the capsule on the outside. So we'll necessarily have to take a parathyroid gland away on each side and hopefully be able to preserve one parathyroid gland on each side. But it's definitely possible that we can't find the parathyroid gland because it's been encompassed by the tumor, or we accidentally damage it, or it just becomes irritated in the course of the procedure and doesn't function normally for some period of time. So problems with the parathyroid would be the biggest concern that we have, that would be specifically related to this tumor being present on both sides. The parathyroid gland is important for controlling calcium in your body, and calcium does a lot of stuff, but it's very important for muscles, including your heart, so it's kind of an important thing. So we have to monitor these patients afterward for signs of low calcium, which can include weakness, seizures, fever. It's essentially preeclampsia or eclampsia. So things that you would see with that condition, you would see with, and one interesting clinical sign that patients with low calcium will exhibit is facial rubbing. It appears to make their face itchy for some reason, but they'll rub at their face, and that tends to be when their calcium's getting fairly low. So here we have the tumor isolated on the first side, and what's a little bit unusual about this is these thyroid tumors in general tend to be super vascular and super fragile. The second you touch them, they start to bleed, and surgery becomes a big bloody mess in no time. This tumor is not bleeding at all, essentially, and it's really well isolated from all the other structures except for the recurrent laryngeal nerve. That is sitting right up on top of the capsule, so I'm kind of carefully peeling it back. Well, I will be, I believe. It looks like I'm still cutting something. But the recurrent laryngeal nerve was sitting on the capsule, and we had to just carefully tease that off. The recurrent laryngeal nerve is important for controlling the larynx, part of the larynx that helps open up the airway to allow you to breathe in and close the airway to keep you from swallowing something down the wrong tube when you're eating. So if that nerve gets damaged, then one of those doors that's supposed to be opening and closing appropriately is now kind of just flapping in the breeze and can actually become an obstruction to breathing, because as you breathe in, the door swings in and occludes half of the opening to the airway. And that can become a big problem for some dogs. So that's an important structure that we need to be careful to avoid in a procedure like this. Easy to do if you know it's there and then know to look for it and know what you're looking at. So knowing the anatomy on a procedure like this is pretty important, because it's generally pretty easy to avoid catastrophic mistakes and hitting these big structures, but it's going to be infinitely more challenging if you either don't know they're there or don't know how they're associated with what you're working on, so you don't know how close or far they might be. So the other things that we're being aware of in this area, and right now this mass is just elevating out of the incision so nicely and is so well isolated and encapsulated that we don't have to really worry about them. But the structures would be the carotid artery, and very closely associated with that, the vagosympathetic trunk, a very big important nerve and a very big important artery. So those are structures that we would definitely want to be aware of and avoid, but again, those are going to be pretty deep to where we're working. They're going to be down right up next to the trachea, and yeah, this mass just came up and out so nicely that we definitely don't need to be too concerned about where those things are right now. Gosh, it was almost like doing a neuter once you got in there. Just this little mass with a bit of connected tissue and a blood vessel. So here I'm trying to be very careful and make sure that I am staying away from that recurrent laryngeal nerve that I worked so hard to peel off of the outside of the tumor. It's still in that connective tissue there that's hanging down from the tumor. It's just there's a small space between where that nerve is running and the gland. So I'm trying to be really careful to not cut the thing that I just took so long to try to preserve. I'm also trying to be careful about bleeding because, again, these typically bleed a lot and a lot more than this one currently is even. But also, tumors are really good at recruiting blood vessels to them to help feed them. And I want to be careful that I don't accidentally cut through a relatively large vessel and get a whole bunch of blood in the surgical field and make it hard to identify what's going on. And there definitely are large abnormal vessels being recruited. I think you can see one sitting on top of the trachea right there, but there definitely were large new blood vessels in the area that these tumors had recruited. Cancer is pretty greedy and it needs a lot of fuel to be able to grow. So here I've been palpating through and trying to find the parathyroid gland. In a normal thyroid, usually it's just sitting right on top of the cranial pole of it, and it's kind of obvious. But here it was a little harder to find, but I have it isolated within that capsular tissue, that like connective tissue. It's sitting basically right in front of my thumb. And so I'm trying to cut between the thyroid and the parathyroid. There's not much I can do about being careful to preserve the blood supply or not. There's a specific little branch of blood vessel that goes right to it that in some cases, like a more benign thyroid adenoma in a cat, you can identify that vessel and try to avoid it. But in a case like this, I just want to make sure the gland stays in there. And there's a good chance that it will work just fine, even if there is some blood supply disruption. If you take the entire gland out and chop it up into tiny pieces and then implant it inside one of the muscles there that you have exposed, that tissue can, in a lot of cases, take hold and grow and do its normal job. So I think these parathyroids will work just fine, although they may be insulted by the surgery, and it may be that we have to supplement with some calcium or even start a medication called calcitriol. And that would be to keep the calcium level up until the parathyroids got back online and were able to help balance things out on their own. Usually if the body needs more calcium and it's not being immediately provided in the diet, it will just scavenge some from bones, and then when the body doesn't need as much calcium, it'll put calcium back into the bones. But in this case, the problem is we don't have the signal, the hormone, to tell the body, hey, get some calcium out of the bones. So we have to supplement it ourselves. So we have the one thyroid gland out. The other side is essentially the same. So I'm going to speed it up a little bit for the second half here. So starting here on the other side, we're just dissecting down to expose the tumor. And we found the tumor, and now that structure right here is the recurrent laryngeal nerve. I'm very carefully just kind of scraping that off. A periosteal elevator works pretty well for this too. But I'm lazy and I just used what I'm already holding. Now that I've got some good distance between the nerve and the tumor, we'll just use our cautery to buzz through that connective tissue. Now we should be close to that parathyroid if it's in the same neighborhood as it was on the other side. So we're going to feel around and see if I can palpate it. And there it is right there. I can feel it. So now I'm just going to try to dissect enough that I can see a clear space between the thyroid and the parathyroid where I can amputate that mass. If you can see a tiny little yellowish structure just past my fingertips, that's the parathyroid. So we're going to amputate right between the parathyroid and the thyroid. Yeah, show that to the camera. Complete fail. And from here, it's just closing up. We'll close the muscle bellies together, then the subcutaneous tissue, and then the skin. I always close with an intradermal pattern in the skin so there's no sutures visible, and it's easier to deal with post-operatively if there's no sutures to remove, and it's cosmetically appealing, and yeah, it doesn't take much longer. So anyway, that's that surgery. Just a very interesting case, as it is rare to see a functional thyroid tumor in a dog, and really uncommon that you would see it bilaterally. But yeah, this was a good case. It should have a good outcome. Taking those tumors out, the dog's clinical signs should almost immediately go away, and after some time, if the parathyroid glands are having issues, I would expect that they would come back online and function properly as well. So with that, I'll probably leave you all. Thank you very much for watching. If you made it this far, please feel free to comment down below. I try to respond to every comment, or as absolutely many as possible. It really is my passion to help just share information about the veterinary profession, and I would love to be able to answer any questions that I can. Thank you all for watching. Stay safe, and we'll see you next time.